So, I'm starting today with just a disclaimer that you all have access to the DSM and should read this chapter before proceeding with the lecture. You should be reading through each chapter as we move through to familiarize yourself with the DSM as a reference text. No memorization is required, and out in the field, as you're practicing and diagnosing, you'll want to rely on the text instead of memorization anyway. There's just too much in there to remember. So, today I'm not going to go over the diagnostic criteria so much since you'll get that from your reading, but rather my purpose is to give you a little bit of color, background noise, some understanding outside of what the DSM outlines. This chapter of the DSM considers conditions that other professions might judge as bad behavior. Fortunately, we have the luxury of not having to judge our clients. Rather, we can study them from curiosity and why these behaviors are occurring and learn how to treat them. These disorders entail problems with the regulation of behavior and emotions. The behaviors in question may occur in the spur of the moment or they may be planned. Some are accompanied by efforts to resist. And the acts themselves are often illegal with consequences associated with them, often causing injury to the clients or to others. This chapter of the DSM has the following disorders in it: oppositional defiant disorder, intermittent explosive disorder, conduct disorder, antisocial personality disorder, pyromania, kleptomania, and other specified and unspecified. Now, you might be thinking, wait, antisocial personality disorder is a personality disorder. It is, you're right. We already talked about that one last week, but it makes a special guest appearance in this chapter too because of overlapping symptoms. And when we're looking at a spectrum of development over time. What is not in the DSM chapter that I am covering today is disruptive mood dysregulation disorder. That disorder lives in the depressive disorder chapters, and we haven't talked about that one quite yet. I'm just bumping it up to today's lecture because I think conceptually it fits with our topic area a little bit better today. So each disorder in its own way brings the client into conflict with what we understand as social norms. In each, you'll see that males have higher diagnostic rates than females, except for one. Guess which one it is? And all typically start in childhood or adolescence. Sometimes there's a progression, for instance, from oppositional defiant disorder to conduct disorder to antisocial personality disorder. However, we must not draw the mistaken conclusion that having one foot on the pathway means eventual arrival at the end of the trail. In fact, the majority of individuals with oppositional defiant disorder do not go on to develop conduct disorder, just as most individuals with conduct disorder do not progress to antisocial personality disorder. Still, in an important minority of individuals, there is that developmental arc. So, oppositional defiant disorder ushers in a triad of disorders spanning the spectrum of behavior from resistance that is barely outside the expected to acts that are considered atrocious. Oppositional defiant disorder requires only 4 of the 8 listed symptoms and is characterized by negativistic, hostile, and defiant behaviors that interfere with functioning. And these behaviors are considered to not be developmentally normal for that person. So, you might want to consider age, intellectual ability, and the DSM even differentiates in behavioral norms between boys and girls here too. So you'll want to think about how puberty, adolescence plays a role here too. Lots of mood swings, lots of stuff going on in developing brains and bodies, and also consider how the presence of social media during adolescence might heighten some vindictiveness too. I can't imagine that if social media had been around when I was in middle school, high school, that it would have been very helpful to my little brain and self-esteem. So we're also going to look at how the brunt of the symptoms associated with this disorder are pointed at least one specific person who is not a sibling. So we want to get curious. Who is that person? Are they rewarding the behaviors in some way? Are they a perpetrator and our client is the victim? Because if either of those are the case, we're going to consider to defer from this diagnosis and look at some other rationale and reason for the behaviors. And although some cases of oppositional defiant disorder eventually meet criteria for conduct disorder, symptoms tend to disappear with age. Some researchers even argue that because the development from ODD to conduct disorder is so infrequent that we should not consider them a part of the same spectrum. But the current DSM does, so that's how we're grouping them today. So it's just worth a little bit of thought here. Do they really belong in the same chapter? If not, how would we best rearrange the chapters? Also, the boundaries of oppositional defiant disorder remain problematic. Many children have oppositional behaviors, and almost every child shows them some of the time. Have you ever met a teenager? Oppositional defiant disorder itself can be relatively mild with symptoms of negativism and defiance that seem to grow out of any child's normal quest for independence. On one hand, they are distinguished from normal opposition by severity and duration. On the other, they're distinguished from more problematic conduct disorder by the fact that children with ODD don't violate the basic rights of others or age appropriate societal norms. The pattern has to be present in multiple situations, not just with teachers or parents, and a requirement has been that children be oppositional most of the time. In the end, one still has to decide on clinical grounds whether or not to diagnose ODD. And one symptom often deliberately annoys others and blames others for his or their mistakes or behavior. Again, we're looking at developmentally appropriate. I remember when I was a kid, my brother and I, we were in elementary school, and he's 2 years older than me. And, I'd be sitting in the back of my mom or dad's car, and we would be going somewhere. And one of us would just deliberately start to annoy the other, like poking, tickling, breathing on, staring at each other. And it would be this whole game of kind of annoying each other. And it was amusing to be the annoyer. It was really awful to be the annoyed, but we go back and forth doing it, not for any really great reason. It was just really awful to pick on each other. And I'm sure our parents were the most annoyed out of anyone. But yeah, that's developmentally appropriate. And we were siblings. So remember, this has to be a non-sibling that the behavior is engaged with. And it doesn't say it has to be an adult. So it can be a peer with whom they're deliberately annoying. And I want to note that individuals with oppositional defiant disorder typically do not regard themselves as oppositional. They justify their behavior in response to unreasonable demands or circumstances. And this is really key here. Knowing the motive or justification behind behaviors, it's really important to identify what that person's perception is. If they're argumentative, defiant in order to protect themselves because they're fearful, that could be responsible for the trauma that they're perceiving. So behaviors could be something just as a result of experiencing consistent discipline, or maybe they perceive any demands upon them to be unreasonable. Those are two very different sort of people. The symptoms for ODD first show up around age 3 or 4. Diagnosis is typically made a few years later. Younger children will show oppositional behavior almost every day, whereas for older children, the frequency tends to decline. The effects are worse at home, though relationships with teachers and peers can also be affected. Younger age and more severe symptoms at onset predict a worse outcome. The DSM-5 does caution us to consider possible modifying factors such as developmental age, culture, gender. It notes that symptoms must occur with people other than siblings. And though ODD runs in families, genetic relationships are not certain. Some researchers attribute ODD to harsh and inconsistent discipline, and others attribute it to imitation of parental behavior. Low socioeconomic status may contribute to the stress of living at or near the poverty line. So we've got cases for both nature and nurture here, where usually it's a combination of one or the other, and sometimes it seems like it's neither. So here's another way to think about that nurture aspect with all of the conditions today. If the child's born and they're neuroatypical as an infant and they can't communicate, Mom, that's too hot, or Dad, that's way too cold, or it makes me itchy, or it hurts when you do that, they can't communicate any of that. So normal caregiving behaviors like swaddling, diaper changes, bathing, feeding a lukewarm bottle may actually be painful to the child. So the caregiver has become associated with the pain. The child is deemed fussy or high needs, and in reality, they're just trying to communicate, and the only way that they can is by crying. So we need to take a look at that and not just blame the parent and say that it's due to parental behaviors. This parent may have been doing their very best to be a good caregiver, but inadvertently traumatize the child. So we need to be sensitive to those things and be curious, but not condemning of the course and the development of behaviors. So along with conduct disorder, oppositional defiant disorder is among the most common reasons for referral to mental health professionals. It affects about 3% of children, mostly boys, with a broad range depending on the study of 1% to 16%. And while it does occur in girls, its expression may be a little bit more verbal and less obvious. So you might argue that it's not caught in girls as often. And to clarify, in Western cultures, you'll see this mostly in boys, but in non-Western cultures, it ends up being seen equally in boys and girls. So I wonder what your thoughts are about that. Over half of those who initially meet ODD criteria will not several years later. However, conduct disorder can develop later in about a third of individuals, especially those whose ODD begin early and coexists with attention deficit or hyperactivity disorder, ADHD. These diagnoses are strongly comorbid and travel together. So perhaps 10% will eventually be diagnosed with antisocial personality disorder, disorder. The irritable mood symptoms of ODD predict later anxiety and depression. Defiant symptoms point toward conduct disorder. ODD can be diagnosed in adults, and sometimes it is. It's been reported in 12 to 50% of adults with ADHD. And 50% seems a little high to me, so I'm not sure that I want to co sign that quite yet, but it's worth mentioning that there is research out there. So, in adults, the symptoms of ODD may be obscured by other disorders, or they may appear more frequently as a personality disorder. The reported prevalence of oppositional defiant disorder or other disruptive disorders may be affected by misdiagnosis or overdiagnosis of individuals from some cultural backgrounds. Consider social norms, socioeconomic status, how we're measuring the symptoms, what cultural lens are we looking through to decide what is normal versus what is abnormal. Also, some research suggests that first-generation migrants and refugees may be at a decreased risk of developing oppositional defiant disorder symptoms. So I thought that was interesting. The Diagnosis of Conduct Disorder, which lists 15 symptoms and requires that 3 of them be present for at least a year. These symptoms are categorized as aggression, destruction, lying and theft, and rule violation. And there's an additional specifier for callous and unemotional traits, which is set to consistently predict an outcome of antisocial personality disorder in adulthood. A long list of symptoms is required for diagnosis for that, and a pattern of aggression towards people or animal, property destruction, deceitfulness, serious failure to follow the rules. It's clearly pathological, but only 3 of 15 criteria are required to meet diagnosis for conduct disorder, making it one of the most diversely presenting diagnoses in the manual, meaning that each individual might present in vastly different ways and still be lumped under this one diagnosis. Some of the variation is captured by the severity modifiers in the DSM-5, like mild, moderate, or severe. From as early of an age as 2, boys will typically exhibit more aggressive behavior compared to girls. However, a significant minority of children continue to display aggressive rule-breaking behavior beyond this age. For some individuals, the symptoms of conduct disorder may represent an exaggerated form of normal attempts to assert independence from their parents. So think of Erickson's stages like autonomy versus shame and doubt here. However, it's important to note that most conduct disorder symptoms, whether occurring in childhood or later, are severe and can lead to legal consequences such as arrest. Conduct disorder is characterized in part by the extent to which a child's family, social, or academic life is impacted by such behavior. Contributing factors may include environmental factors such as large families, neglect, and abuse, as well as genetic factors such as family members with substance use, conduct disorder, ADHD, and psychosis, and of course, a history of trauma. So, conduct disorder can be conceptualized as a response to early childhood trauma in several ways. The first being maladaptive coping mechanisms. Children who experience trauma at a young age may develop maladapting coping mechanisms to deal with the distressing experiences that they have encountered. And this could include aggressive behavior, rule breaking, or defiance as ways to cope with their emotional surroundings. Coming from an attachment theory lens, this disruptive attachment idea is that early childhood trauma can disrupt the formation of secure attachments with caregivers, leading to difficulties in regulating emotions and behaviors. Children with insecure attachments may struggle to trust others, leading to challenges in following rules and social norms. And then we might look at modeling behavior. Children often learn behaviors through observation and imitation. If they're exposed to violent or abusive behavior in early childhood, they may internalize these patterns and exhibit similar behaviors themselves, contributing to the development of cognitive disorder. And as far as emotional dysregulation, trauma can dysregulate a child's emotions, leading to difficulties in managing anger, frustration, and other strong emotions. So if you like polyvagal theory, you might consider that movement from flat to furious or ventral vagal through sympathetic to dorsal vagal. And this acting out can be seen as a way to take control of freeze and move back into flight. And from a CBT lens, when we think about cognitive distortions, early trauma can shape a child's beliefs and perceptions about themselves, others, and the world around them. And this could lead to cognitive distortions such as a skewed sense of trust, wholeness, or belief that others are hostile or threatening, contributing to antisocial behavior. So many things can be an influence on how or why a person might develop conduct disorder, and we should especially look at instances of trauma in their history. Some of the issues that require further research are whether the existing criteria work for girls, whether requiring the the presence of callous, unemotional traits defines a valid subtype and whether dimensional conceptualizations of ODD and CD can be justified. And by and large, ODD and CD are broad diagnoses that describe a range of behavioral problems. As with depression, disorders that cover a too wide range may eventually need to be divided up, but that can't happen until we have a better knowledge of the causes or the etiology. And about 80% of children diagnosed with conduct disorder have previously had ODD. In fact, some researchers question whether ODD and CD are two disorders or one. And before I talked about others wondering if they even belong in the same category. So you can see the DSM is imperfect. They might belong in different categories. They might be the same diagnosis altogether. We don't know. But what do we really want to know about all of this? And it's to what degree will such behavior persist into adolescence and beyond? And what about conduct disorder in adults? As with oppositional defiant disorder, the diagnosis is at least theoretically possible, but it's far more likely that an adult will have some other disorder that will obscure the conduct disorder symptoms. So, as I talked about in your introduction to psychopathology and diagnosis video, never look for a psychological explanation unless every effort to find a cultural one has been exhausted. This is especially true for conduct disorder. Conduct disorder diagnosis may at times be misapplied to individuals in settings where patterns of disruptive behavior are viewed as near normative. So, like in a very threatening high crime area or war zone. I'm even thinking about that TV show Shameless, where the kids Lip, Ian, Carl, Debbie, I think there was another one. We could probably find 3 symptoms to diagnose for each of them, but this was survival for them in the early years of that show. And then they all went on to develop some other coping skills to get their needs met. And over time, maybe some other possible diagnoses for each of them came more to the forefront. So therefore, in the context in which the undesirable behaviors occur should be considered. In youth from underserved ethnic or racialized groups, reactions to racism that involve anger and resistance-based coping may be misdiagnosed as conduct disorder by uninformed practitioners, as suggested by the association between experiences of discrimination and adolescent onset conduct disorder within these groups. As counselors, we need to recognize the power and privilege that we have, especially when diagnosing, and be sure that we're not using a diagnosis to further oppress an oppressed society, culture, or individual. This is why looking at the symptoms holistically is important. If we can explain behaviors as something other than a diagnosis, we should make every attempt to do so. And I want to take a little extra time to discuss the specifier with limited prosocial emotions, which asks us to engage in the emotional underpinnings of or reactions to that behavior. Conduct disorder behavior can take either of two forms. In one, the individual has trouble regulating powerful, angry, and hostile emotions. These children tend to come from dysfunctional families that are prone to physical abuse, though again, maybe not. But because these behaviors don't quite fit with the social norms, they're likely to be rejected by their peers, leading to aggression and truancy. Rather than possessing emotions such as anger and hostility, a minority of individuals with conduct disorder lack something: empathy and guilt. These children tend to use others for their own gain. With low anxiety levels, the tendency to become easily bored, they prefer activities that are novel, exciting, even dangerous. We might want to look at the links between dopamine and adrenaline and norepinephrine here and see how these neurotransmitters are being gated and produced. Because of this, novel, exciting, dangerous-seeking behavior to me sounds not unlike someone who is seeking high adrenaline experiences like skydiving or bungee jumping, adrenaline junkies. They just might not have the means to be jumping out of airplanes every day and resort to some dangerous act that's more attainable in the moment. So when we're activating these stress responses over and over, maybe through repeated complex trauma or maybe through dangerous activities as a way to regulate, it's thought to drive compulsive behavior through a negative reinforcement mechanism. So to me, what this sounds like we're talking about here is the language of addiction. The release of norepinephrine in the amygdala, the area of the brain activated during the stress response, may create a dependence on the flood of that neurotransmitter. Another study focused on avoidance types behaviors that are found in PTSD, and in this study, researchers found that the amygdala stimulation leads to a decreased avoidance behaviors. So if you didn't follow any of that, that's okay. Just some stray thoughts of what might be going on with the brain's wiring. And a little note about antisocial personality disorder. So last on the path that often connects with ODD and chronic disorder comes antisocial personality disorder, which is more or less the culmination of aggressive, destructive behavior with that lack of empathy and guilt. So if you're looking for a spectrum or a progression here, it's often thought that it could go from ODD to conduct disorder and then to antisocial personality disorder. But again, those don't necessarily have to develop. They develop in the minority of people we're looking at. And so we're moving on to intermittent explosive disorder. And so the empirical literature on IED is thin. A 2008 study suggested that IED is common in the community with a lifetime prevalence of 7% and a 12-month prevalence of 4%. And these are high numbers, but given the imprecise criteria for the diagnosis, I wonder if researchers counted everybody with road rage as a case. So similar questions arise concerning recent report claiming IED can be diagnosed in 7.8% of all adolescents. Once again, epidemiology is suspect when it relies on fuzzy DSM definitions. Some argue that IED is caused by abnormal serotonin activity, and the diagnosis has sometimes been used in court to reduce assault charges when actions were unplanned or impulsive. Whatever you think of intermittent explosive disorder, it's a condition with a long pedigree. Although it wasn't listed per se in the first DSM, the concept was there. Hiding in plain sight on page 36, it was masquerading as a passive-aggressive personality, aggressive type, whose symptoms were persistent reaction to frustration with irritability, temper tantrums, and destructive behavior. And then in the DSM-2, it was called explosive personality, which in the DSM-3 in 1980 had morphed into the familiar intermittent explosive disorder. And with such a long history, it's surprising that proper investigation has taken so long to begin. It's enough to make a person angry, like really, really angry. People with IEDs have periods of aggression that begin suddenly, the classic hair trigger temper, or we see that flat to furious on the little to no provocation. The stimulus might be quite benign, an offhand comment from a friend, an accidental bump from a passerby on the sidewalk, and all hell breaks loose. The form the particular hell takes may be only verbal, but the actual physical violence is also a possibility. In either case, a situation may rapidly escalate, sometimes to the point where the individual completely loses control. The whole episode rarely lasts longer than half an hour or so and may end up with the person expressing remorse or posting bail. Outbursts are not premeditated and are not committed to achieve some tangible objective. That helps us differentiate intermittent explosive disorder from antisocial personality disorder. For example, the person doesn't think, can I intimidate this person to get their wallet or to get their car? This diagnosis is not premeditated, involving unpremeditated outbursts. So I think the description in the title is pretty well. It doesn't have to happen all the time. It's intermittent. And when it does happen, it's large and it's loud and it's a big deal, maybe with some wreckage. Individuals with intermittent explosive disorder are mostly young males, and many are relatively undereducated, less than a high school diploma. The condition affects as many as 7% of Americans' lifetime, or 2% in the previous month, and the figures are higher for young people and for those whose education stopped with high school. Reported rates are considerably lower in other countries, so I take it that America is just a really angry country. Up to a third of first-degree relatives also have intermittent explosive disorder. Some authorities suggest a strong genetic component, but a history of childhood trauma is also higher in individuals with IED than in comparison groups. We might go back to the conduct disorder slide where we talked about how trauma can manifest into angry and antisocial behaviors. Intermittent explosive disorder comes attended by other mental conditions, including substance use, mood, and anxiety disorders. The IED usually begins first as a substantial number of years. And clinicians note that in the case of individuals with bipolar 1 disorder, it's important to make the IED diagnosis only when the individual is not in an episode of mania. What's important about this is that we should vigorously attempt to rule out other possible causes of explosive episodes before diagnosing this disorder. So something new in the DSM for this disorder, and new in the DSM for any disorder, is with the IED diagnosis, it's relatively benign aggression twice a week for 3 months, or harmful assault 3 times a year. So, no other condition features intensity based versus frequency based dual qualifiers. So, of course, the criteria for nearly every other disorder allows for differing degrees of severity, but they're stated in terms of numbers of criteria met, or quality or frequency or duration of the criteria that are demonstrated. The way it's stated here, IED occupies a niche unique in the diagnostic spectrum. The justification for this duality is the observation that there are basically two patterns of outburst: high intensity, low frequency, or the reverse, and that limiting the definition of one group omits considerations of a considerable proportion of individuals who repeatedly have problems related to their aggressive impulses. In actuality, individuals with IED may mix the two patterns of behavior, and the DSM-5 assures us that regardless of which pattern an individual shows at intake, outcome and response to treatment will be roughly the same. And isn't it odd, though, that we aren't encouraged to add some sort of specifier that would tell the world just which bar the individual cleared to gain admittance to this diagnosis? Disruptive behavioral disorders can present with mood instability, and some of the most severe cases of this kind may be diagnosed as pediatric bipolar disorder. However, members of the DSM-5 task force were cautious about the concept of bipolar disorder in children, in part because it leads to frequent prescriptions of mood stabilizers and antipsychotics that might do more harm than good when started this early and used long term. DSM-5 has therefore introduced a new term focusing on children who are more likely to be angry and irritable than sad or elevated. This new category, disruptive mood dysregulation disorder, is a condition mainly defined by frequent outbursts of rage in children older than age 6. There's little research to back up this new category, which is puzzlingly listed under the depressive disorders rather than under the disruptive behavior disorders. In any case, because children often have temper tantrums and usually grow out of them, we should be careful about giving this psychiatric diagnosis to young kids. Doing so is discouraged by requiring that children be at least 6 years old. Even so, it's not clear whether this diagnosis will discourage aggressive pharmacological treatment in children associated with diagnoses of pediatric bipolar disorder or this new one. Among other things, two manias are included in this chapter: pyromania and kleptomania. Another mania, trichotillomania, has been moved to the new DSM-5 section on obsessive compulsive and related disorders. But in these disorders, the term is not used by itself in the sense of having a manic episode. Rather, as a suffix, it means having a passion or enthusiasm or madness in Greek for something. As with the relationship of kleptomania to shoplifting, pyromania accounts for only a small minority of fire setters. The diagnosis can be made when there's a consistent history of relief achieved after participating in the irresistible impulse of setting a fire. At least 80% of people are male. Often the behavior begins in childhood, and with their interest in various aspects of fire, they will turn in false alarms, appear as spectators at fires, or collect apparatus used by firefighters. They may even serve as volunteer firefighters, thereby becoming their own best customers. Although pyromania is classified as an impulse control disorder, these individuals may make advanced preparations such as searching out a site, collecting combustibles. They may also leave clues almost as if they want to be identified or apprehended, and fire setters may have low self-esteem and reportedly often have problems getting along with their peers. So look for coexisting conduct disorder or antisocial personality disorder, substance misuse, and anxiety disorders. And as a freestanding diagnosis, pyromania is probably very rare, with more instances reported in males. In kleptomania, stealing occurs not only as the result of need or even necessarily of desire. When caught, these individuals typically have enough money with them to pay for whatever they've taken, and once they've left the scene undetected, they may give away or discard their loot. They often recognize that their behavior is wrong but cannot resist it. Fear of apprehension, guilt, depression are frequent accompaniments. Okay, many otherwise normal people have stolen something. Over a quarter of college students in one study admitted to it, but fewer than 0.5% met criteria for kleptomania. The diagnosis is much more common, up to 8% in individual samples. So it's especially common among younger people. Indeed, it typically begins in adolescence. So highlighting a diagnostic criteria here: failure to resist impulses to steal unnecessary objects. So, if you have somebody who is using heroin daily and lost their job or their family support and really no way of obtaining money for their heroin, they may resort to stealing. But that theft in their minds, and when we look at addiction, could be argued as necessary. So, they probably wouldn't meet the diagnosis for kleptomania. So women outnumber men perhaps 2 to 1. And this is the only one that we're talking about today where women are going to outnumber men. And once it begins, often in childhood, it tends to be chronic. Dating back over 200 years, kleptomania is one of the oldest named disorders in the diagnostic manuals. It's probably also highly overused. Although fewer than 1 in 20 shoplifters can be accurately diagnosed with this disorder, many try to avoid prosecution when they're caught by claiming that they were driven by an irresistible impulse. Look for substance misuse and depression as comorbid diagnoses. Tension and release or relief is a phrase that describes several DSM-5 conditions. Among them are pyromania and kleptomania, but it can also be found in trichotillomania. It expresses the typical buildup of anxiety or tension, sometimes for a day or more, until the impulse to act becomes overwhelming. Once the action has been taken, the person experiences a sense of release that may be perceived as relief or pleasure. However, remorse or regret may later come to dominate the emotional landscape. So, this group is an orphan left over from previous manuals that don't really find a place anywhere else. Sometimes diagnoses don't really fit and end up being separate chapters, but this group includes 2 important conditions that psychiatrists often see. One thing to consider here, pathological gambling used to be part of this impulse control chapter. It's been moved over to the group of addictions, but it has so many overlapping components that you could conceptualize it in the same way. So, other specified disruptive impulse control and conduct, and unspecified disruptive impulse control and conduct disorders. So, use one of these 2 categories to code any problems with the control of impulses or conduct that do not meet the criteria for the disorders described before or elsewhere in the DSM-5. As usual, the other specified category should be used when you wish to be specific about a particular presentation. The unspecified category should be used when you do not wish to be specific. And we've got a little smattering of differentials to consider here. So, antisocial personality disorder. The irresponsible, often criminal behavior of people with antisocial personality disorder begins in childhood or early adolescence with truancy, running away, cruelty, fighting, destructiveness, lying, and theft. And in addition to criminal behavior, there's a lack of empathy and remorse. Trichotillomania, which I just talked about, the hair pulling disorder. So, pulling hair from various parts of the body is often accompanied with feelings of tension and release, like we talked about for kleptomania or pyromania, but we want to look at that more now as obsessive compulsive and in that chapter. Paraphilic disorder. So, some people, nearly always males, have recurrent sexual urges involving a variety of behaviors that are objectionable to others. They may act upon these urges in order to obtain pleasure. Substance-related disorders, there's often an impulsive component to the misuse of various substances, so we want to look at that and consider that, but we also want to make sure that if there's substance use present, they might not meet criteria for something like kleptomania conduct disorder. Bipolar 1 disorder, individuals with bipolar 1 may steal, gamble, act out violently, and engage in other socially undesirable behaviors, though this happens only during an acute manic episode. Schizophrenia, which we've talked about already, in response to hallucinations or delusions, individuals with schizophrenia may impulsively engage in a variety of illegal or otherwise ill-advised behaviors. Disruptive mood dysregulation disorder, we talked about that one, but I'm just going to mention it here again because it doesn't actually live in this chapter. So a child's mood is persistently negative between frequent severe explosions of temper. And child or adolescent antisocial behavior. This one doesn't live in the DSM. It lives more in the ICD. It's an ICD code. And this code can be useful when antisocial behavior in a young person cannot be ascribed to a mental disorder such as oppositional defiant disorder or a conduct disorder. And the same goes for adult antisocial behavior. So it's an ICD code not living in the DSM, and it describes activities by an adult that are illegal but do not occur in the context of a mental disorder. And then I really wanted to focus a lot of this on autism and ADHD. So when we look at these diagnoses, they can sometimes be confused with oppositional defiant disorder or conduct disorder due to the overlapping symptoms and behaviors. And here's how each condition might be confused with the other. So we can look at social differences. Both autism spectrum disorder and ADHD can involve social challenges. Children with ASD may struggle with social interaction, communication, and understanding social cues, which can lead to apparent defiance or opposition when they do not respond to social norms or expectations in the same way as their peers. Similarly, children with ADHD may have difficulty maintaining attention in social situations, leading to impulsive or disruptive behaviors that can be mistaken for defiance. And then when we talk about impulsivity and defiance, impulsivity is a hallmark feature of ADHD, but it can also be present in children with ODD. Children with ADHD may act without considering consequences, leading to defiance and opposition, where they resist rules or authority figures. Similarly, children with ODD may exhibit defiant behavior as a response to perceived injustices or as a way to assert their independence, which can resemble impulsivity seen in ADHD. Both ADHD and ODD involve challenges with authority figures. Children with ADHD may have difficulty following instructions or rules due to their impulsivity and inattention. Likewise, children with ODD may actively challenge authority and resist rules as a way to assert control or autonomy. And when we talk about emotional dysregulation, it's common in all of the diagnoses that we talked about today, including ADHD and autism. So children with any of these diagnoses may struggle to regulate their emotions due to impulsivity and difficulty with attention, leading to outbursts or tantrums that can resemble the emotional dysregulation seen in ODD. Similarly, children with ODD have difficulty managing their emotions, leading to angry or defiant behavior that can overlap with symptoms of ADHD. So you're seeing a lot of this behavioral overlap. Some behaviors seen in children with ADHD, such as difficulty staying focused, being easily distracted, having trouble completing tasks, can overlap with symptoms of oppositional or conduct disorder. For example, a child with ADHD who becomes frustrated and refuses to comply with instructions may be mistaken for having oppositional defiant disorder or conduct disorder, especially if the underlying ADHD is not recognized or addressed. So it's important to note that while there can be an overlap in symptoms between all of these disorders, they are distinct conditions with different underlying causes and treatment approaches. Proper assessment is crucial for accurate diagnosis and appropriate intervention. So sometimes it might be easier to sort of look at, we're not just picking out criteria that this person meets for a certain diagnosis. We also need to look at all of the criteria for every other diagnosis out there and make sure that they don't meet one of those better. So I have a little case study for you. It's about this guy named Brian. I'm going to read you a story and then I want you to kind of collect some ideas of what's on this slide. So think about symptoms, think about possible differentials, think about medical considerations. I notice I spelled that wrong, family history, and also cultural considerations. I did spell it right that time. So Brian. So from the time he was a teenager, Brian had a flashpoint temper. He had been suspended from the 10th grade for using a pair of scissors to assault a classmate who had teased him about wearing the wrong colors on Clash Day. The following year, the police had visited him for breaking a headlamp on a car belonging to the baseball coach who had called him an out in a close play at the home plate. So after he paid for the headlamp, charges were dropped, and the coach noted that Brian was basically a good kid, just had a quick temper. That year, a neurologist reported that his physical exam, EEG, and MRI were all normal. During his first few years of school, Brian had difficulties sitting still in class and concentrating on his schoolwork. By the time he entered junior high, these behaviors were no longer a problem. In fact, he earned mostly B's and A's, and in the 2 to 4 month intervals between explosive episodes, he was no more trouble than the average kid, his teacher said. Following Brian's graduation from high school, his pattern of periodic temper flare-ups continued pretty much unchanged. After he was fired from 2 successive jobs for fighting with coworkers, he joined the Army. Within 6 weeks, he had received a bad conduct discharge for assaulting his first sergeant with a bayonet. Each of these incidents had been triggered by a trivial disagreement or an exchange of words that could be hardly called provocation. Brian said afterward that he felt bad about his behavior. Even targets of his attacks usually agreed that he wasn't mean, only touchy. When Brian was 25, a judge ordered an evaluation. Brian had been arrested by an off-duty policewoman in the supermarket. He had pushed her after she dumped 15 cans of tuna onto the carousel in the 10 or less express checkout lane. The usual examinations, x-rays, EEG, this time with an esophageal lead, and sleep recordings revealed no pathology, so all within normal limits. He denied ever having delusions or hallucinations. His father, he said, used to rough him up and his mother when he was drinking, so Brian had always been afraid to try alcohol or drugs himself. Brian denied ever having extreme mood swings, but he did express regret for unpredictable, explosive behavior. I just want to get a handle on it, he said. I'm afraid I just might kill someone, and I'm not even mad at anyone. So, if you were diagnosing Brian, which of what we talked about today would you choose? What symptoms are you hearing? What about the family history? We can kind of get rid of thoughts like substance use and bipolar or anything biological, physiological, since tests keep coming back normal. But what cultural considerations can you think of? For me, I'm thinking of intermittent explosive disorder, and here's why. Brian had a history of many outbursts over a period of at least 10 years. The facts of his behavior would not be an issue here. He easily met requirements for age, frequency, disproportionate rage, consequences like marked distress, and lack of premeditation. Rather, a clinician evaluating Brian should carefully search for evidence of other diagnoses that might merit precedence for treatment. Brian's mood showed no evidence of either mania or depression, effectively ruling out temper flare ups that could be associated with a mood disorder. At wide intervals, he had 2 neurological evaluations, neither of which revealed evidence for seizures. He never touched drugs or alcohol and denied symptoms of psychosis. The presence of any underlying medical disorder might suggest a personality change due to another medical condition, but there was no evidence of this either. Individuals with antisocial personality disorder will often act out violently and unpredictably, but unlike Brian, they do not feel remorse afterward. So neither did he show manipulation, deceit, or callousness that are required by the DSM-5 for antisocial personality disorder. Individuals with borderline personality disorder will sometimes have temper outbursts and engage in fights, but the generic criteria for the personality disorder urge us to rule out other mental disorders first. So if you landed on a different diagnosis, drop it in the comments below and tell me why. Like I say, diagnosis is more of an art than a science. There can be multiple good answers here. Trying to squeeze people into the diagnostic boxes often leads to a lack of seeing a person holistically. So intermittent explosive disorder can be one diagnosis. Perhaps there's a better one out there. Perhaps we don't have enough information to make a diagnosis yet either, and that's okay. If you'd abstain from diagnosis, let me know what other information you might need. Today, we looked at the realm of disruptive impulse control and conduct disorders, which encompass a range of behavioral issues commonly observed in children, adolescents, and even adults. We explored the characteristics, diagnostic criteria, and potential causes of these disorders, along with the differential diagnoses and cultural considerations. Additionally, we discussed the impact of these disorders on individuals' lives, relationships, and overall functioning, as well as the importance of early identification and intervention strategies to mitigate their effects and promote positive outcomes. This information comes from the DSM chapter on disruptive impulse control and conduct disorders, along with contemporary research done on these topics. If you have any questions, please feel free to reach out or comment below.